Great. So let's start the things. Yeah. So sorry, I got a call. So let's start before wasting the time. So those who are new, right? I'll not go much in detail today for all the things, right? This is what we are doing in all, right? So we are preparing, we provide ProMetric 1000 book ebook, online coaching and subscription, Oman Viva coaching. Dr. Anjali Sawant is with us in the lecture. She is also taking care and she is head of our data flow department. So anybody who has a data flow, any queries, exam booking queries, documentation, anything, you just feel free to contact Dr. Anjali Sawant. She is based at Dubai now. So you can call her or contact her. I'll share in our group WhatsApp. Again, I'll drop her number so you can directly approach her. She's in the class as well. So we provide short, we provide mobile applications and everything. Those who did not so far downloaded our mobile applications, use it, do it. We are we updated extremely well these mobile applications all on Android and iPhone, so that definitely helps you a lot. So again, mobile application is very important. This is myself, Dr. Munjal, with good experience in hemato-oncology. This is Dr. Arti, who is a consultant pediatrician. Dr. Mehdi is emergency physician slash cardiologist. She is a gynecologist. Dr. Shikha Garg. She is Dr. Ankit Patel. He is a gastro and gastrointestinal and gastroenterologist. This is our contact detail, and these are our latest hard copy book. Those who wants, they can order it online, right? It's with discounted rate on combo package, so you can order it, right? And extremely the biggest news is that for last 115 days, we had announced a quite big discount on coaching. It is now 50%. So earlier, those who cannot able to join because of the cost constraint, it is now more than 50% discounted now, so everybody can get advantage of it. So that's it, and let's now quick come to our main business, the mock test. Get ready with the pen and paper. Write the first questions in front of your screen. Try to understand the questions. Try to do the three things. Those who are first time attending my lectures, right? We'll get later on the feedback. Never ever miss the three things before starting the lectures. This triad always keep in mind while you are this. You must know any MCQ when you are solving the MCQ. You must know the diagnosis of MCQ. You must know the investigation. It has again bifurcation: initial investigation, based investigation, highly sensitive and specific investigation, blah blah. This is exactly what they ask in the exam. And third is the treatment part. In treatment, even you can make it bifurcation: initial treatment, based treatment. It's little different. The meaning of both is different: initial treatment, based treatment. So when you're treating any leukemia, initial treatment is you give the hydration and try to prevent the tumor lysis, and base treatment is chemotherapy, right? So probably initial treatment would be different from the base treatment. So you must know all the things, right? So let's jump to the first question. So always keep in mind these three things while solving any MCQ: diagnosis, investigation, and treatment. So let's set your mind and jump to the first question. A 29-year old primigravida at 22 weeks gestational, present with pelvic pressures and vaginal discharge. On examination, the cervix is 8 centimeter dilated. Fetal membranes are bulging into the vagina. What is the best next step in the management? Rescue, circulage, tocolysis, antibiotic, beta-methazone, rule out the infection. So take your time for 10-15 seconds. Do let me know what's going on. Take your time. If you had given the answer, do let me know what's your answer. I want to understand, right? So Dr. Gulsen is there in the group. Gulsen. Dr. Gulsen is there.
Yes, sir, I'm here.
Yeah. So just tell me, doctor, first of all, what is the diagnosis? As I told you, is it the first lecture for you, doctor?
Yeah, yes, doctor, yes.
This,
Not, I'm on your group like maybe for 4 months or something.
okay.
But this is the first lecture for me. But I'm specialist. I'm OB/GYN specialist. That's
Wonderful.
why.
We need you. Okay, so just wait. I don't want you to answer. Sorry. Right. I started
Okay.
with the first question for yours because there are lots of people here. Right. So someone is saying Dr. Pudda, Pudda, Pudda. Is there? We Dr. Gulzan here trying to make this sessions interactable. So at least we know why this not, why this not. Right. So yes. Yes, Dr. Naina.
Yes, sir.
Yeah, what's your diagnosis? What's your investigation? What's your treatment? How you treat or manage this patient?
Since I saw that it is only 22 weeks and the cervix is 8 centimeter dilated, I thought it can be a cervical incompetence.
Cervical incompetence. Okay, fine. So what you want to do? What is the ideal
And since it's
age?
only,
13 to 16
uh,
weeks.
Yeah, go one by one. It's open for all. Let us speak one by one. So what is the ideal age for doing the cervical encirclage or trying to prevent the cervical incompetency or what? I mean, do you have any idea? Yes or no?
16 to 20 weeks.
16 to 20 weeks. Okay. Yeah, I mean, gynec expert can answer any question, but let the other people. Yes. Yes, Dr. Harish, any idea, Dr. Harish? Yeah, you have to speak up, brother. Don't worry about right, wrong. Don't worry about right or wrong. right? So if we speak well, yes, Dr. Gulzan, go ahead. You are expert, so let's enlighten the things.
Okay. Thank you, sir. First of all, this gestation is 22 weeks, so it will be counted as abortion because it's below 24 weeks, and it's obvious that the patient
Yeah,
has discharge and it's already 8 centimeters dilated. That means this abortion cannot be prevented with cerclage or tocolysis, and betamethasone will not work because the receptors for the betamethasone it's not there yet, and because of the discharge, we will
yeah, go
we
ahead.
will because of the discharge we will know that this patient has chorioamniotic. We can assume that she has there might be chorioamnionitis. That's
Okay,
why we need to start antibiotic immediately.
okay,
The infection, the rule out infection may be the thing that we that might be the second thing after starting the antibiotics. That's my
excellent,
opinion.
excellent. No, no, absolutely fine. Any doubt? Anyone wants to ask any questions? Anyone? If you don't ask now, means this topic is not clear to you. It's very important, frequently asked in exams. So why not an rescue circlage? Anyone wants to ask? Madam has already clear cut mentioned, right? That what is this? Any question? We are 40 peoples in the class. No questions? Great. If no questions, that means everyone.
Can I?
Yes, you ask me. That is what I'm
So,
shouting.
at what age, can we start giving beta methazone, sir? At what gestational age?
Gulzan.
After after 28 weeks, we can call for betamethasone that because that's what the time the type 2 pneumocytes start to produce this surfactant. That's the time what they capable to do that. That's why we need to before 28 weeks. It's there is some dilemma. 24 to 28 weeks you can do or you cannot do. It's up to specialist and patient's decision together because there is also some so NICU problems will be there. So maybe the parents doesn't want to take that risk. But 28 to 34 weeks, we need to give it absolutely. Below 28, starting from 24, it's up to patient and the doctor together.
Great. Is that clear? So
Yes, sir.
basically,
Thank you very much.
yeah, so basically this is the literature, right? So she is absolutely right. Little fine adjustment. Sometime book says that first you need to rule out the infection and then you go for antibiotic, right? So cervical insufficiency is defined as a painless cervical dilatation in the second trimester, which is already second. Anything more than 12 is second, right? 12 to 24 is second, and 24 to 36, 37 is a third, if I'm not wrong, right? So this is already in a second. So what they are trying to tell, right? So this is a cervical insufficiency is defined as a painless cervical dilatation in the second trimester that result in the inability to retain a pregnancy. While most cases of cervical insufficiencies are unexplained, infection is the possible cause. Therefore, any patient with painless cervical dilatation should have a workup for possible infections either in the cervical, vaginal, or urinary tract. In particular, a cerclage can be considered only in the patients dilated less than 3 centimeter. In this patient, it's 8 centimeters. So one criteria is there also. Tocolysis and betamethasone are interventions given only in a viable pregnancy, usually more than 24 weeks gestation. Antibiotic administration would be premature at this point of time in the work in the workup, as infection should be ruled out first. So here, overall, the concept is to first fix up the things, fix up the diagnosis, fix up the things, and then you jump for the treatment, right? So by this statistic and by this literature, we first must rule out the infection and then we go for the treatment. What are the indications? Cervical encircle, as madam told, Dr. Gulzan rightly said, right? Perform usually as per the book's number 12 to 20, 14 weeks. Suture encircles, right? Suture encircle cervix to prevent the cervical canal from the dilatation, indicated electively or emergently in cervical insufficiency. That's it. So this is what for the thing is, right? Let's jump to the questions. Now everybody has a pen and paper. Write down your own score, right? I don't want to ask you each and everybody personally, 50 people in this group. Write down 1 out of 1, 0 score, because this is wrong. Out of 1, there is 1. Out of 2, what? So end of this day or my mock, you should have at least 70%. Then it's a good time to go for exam. Believe me, this is general marker, right? So you must have at least 70%. Question number second: 30 years old man and wife present to the reproductive endocrine clinic because of infertility. The man is tall, has bilateral gynecomastia. Examination of testes reveals bilateral small firm testes. Which of the following investigation is most helpful in the diagnosis? So again, keep my triad in the mind, right? What's the triad? Triad is this, right? So always remember this triad: diagnosis, treatment, and investigation, right? So they ask either three questions. In any MCQ, they ask what is the diagnosis. Here they ask diagnosis, what is the investigation of choice, what is the treatment. So they are asking this, right? So first of all, think. You have few seconds in with you. What's the diagnosis? If you don't know the diagnosis, answer will be wrong. You can post the answer. We have 50 people in the group. I want everyone, just I had get 3, 4, 5 responses only. That's it. Everyone post answer. No? What's stopping you to? I'm not asking you why it is right or wrong. No, you try to stretch your brain. Think that if the same question comes in exam, you have to write down and it's something. No? You cannot make it blank. Yes, so I think most of the people are correct, right? This is looks like a Klinefelter syndrome, right? So the diagnosis is that, and what makes the Klinefelters, right? If I ask Dr. Midila, right? Are you there in the class?
Yes, sir. I'm there. I'm there.
Wonderful. Okay, so are you agreed with the Klinefelters?
Yes, sir. Klinefelters, because the features physically resemble Klinefelters, gynecomastia, then a testicular atrophy, whatever is mentioned here.
Tell me the 4 chromosomal
Man, small.
Klinefelters, Down syndrome, Turner syndrome, Patayu. What
Sir,
are the
Edward.
one by one?
Klinefelters is XXY.
1 second. XXY is a Klinefelter. This is called as a trisomy, right? 44 plus XXY, right? Normally
Yes, sir.
we have
Yes, sir.
46, right? If you
Yes, sir.
remember again, 23 pairs is equal to 46 chromosome. So 44 is this, 45 and 46, but this is extra additional X chromosome. Is that
X
clear?
chromosome.
Yes or no? So it is
Yes,
called
sir.
trisomy or XXY. So this is called as a sterile male. This is sterile male, right? And Turner
Yes, sir.
is a sterile female.
Turnus is monosomy, X0.
Yes, sterile female. So this is very frequently asked, and we every time we get confused. What is Klinefelter's chromosome? What is Turner's chromosome? So I want you to mug up today. Klinefelter's is XXY. He is a male. He is a sterile male. That's it. Clear. Turner is a sterile female. Is a monosomy. So there is a 44. X only. O means zero, nothing. So XO. Is that clear to everyone? Yes or no?
Yes, sir.
Down syndrome. What is a Down syndrome?
Trisomy.
Trisomy in which? 1, 2, 3, 4, 5, 6, 23. Which chromosome? Trisomy of what? Extremely
21st
good.
chromosome, sir.
21st chromosome trisomy. Right.
Yes, sir.
What happens in Patayu?
13th chromosome, sir.
So mug up this.
Trisomy.
I make very excellent slide here. So this is classical Klinefelter syndrome. Right?
Yes.
Right. Remember it very well. What is it? Is 47 means total number 47. They mean to say 46, 44, X, X, Y means 47, right? 45, 46, 47, 5, 6, 7, right? So they probably mention 47, X, XY, Klinefelter syndrome. What's the problem? Is a male. Is a male, right? But features are like female. So it's a sterile male, right? So how it's female gynecomastia, which is not there usual in male, male with the female features, right? And inability to produce sperm, small testes, firm testes, right? Frontal baldness like a female absent, tendency to grow fewer chest hair, which is usually not there, breast development, that is a gynecomastia, female type pubic hair pattern, right, which is not commonly seen in small testicular size, right, wide pelvis like female, right, and narrow shoulder, right, and poor beard. That's it. So this is a Klinefelter syndrome. 1 out of 500 or thousands male must go through the life undiagnosed. 40% of embryo survives to the birth. Anyway, so this is all literature. This is extremely important slide. Mug up this slide, ratify this slide, because this will come oftenly in exam, right? Probably Turner, probably Klinefelter, probably Patayu, probably Edward. So we go one by one. Downs is trisomy, extra chromosome in 21 is trisomy 1. So this is very clear cut and easy. Trisomy 21, right? 18 Edward. This is how A pronunciation. 18 A18 Edward, 18 Edward. So extra chromosome 18 Edward. Easy to remember. 18 Edward. Turner, monosomy. Monosomy means 44. XY instead of XY, it is a XO. There is no one, missing one. Deletion of one chromosome, right? So this is the Turner. This is a sterile female. Klinefelter sterile male. We see in the picture. So this is all trisomy 21. Edward 18, extra chromosome. Patayu 13. Patayu 13. 13 Patayu. 13 is a Patayu, right? Turner we already seen, sterile female XO. Klinefelters we have seen XXY, right? Triple X chromosome in female, right? Triple X super female. This is also called as a super female. So we usually XX is female, XY is male, but triple X, right, is a super female. Triple X syndrome, right, in female, and instead of XY, there is XYY. Again, you can say super male. 2Y chromosome in male, right? So this is what the thing is. So don't get confused on the level of chromosome. Probably you need to ratify something, but it's very important too, because they sometimes, many a time they ask Patayu and they ask you the Edward. So we get confused between what 13, 18, 13, 18, 18 Edward, 18 Edward, 18 Edward, 13 Patayu. Rest of the things you can remember down is 21. XXY, it's a Klinefelter's XO Turner, sterile male female. That's it. So if you know these basic things, you can answer lots of questions related with the chromosome. That's it. So this is what the thing is. Turner and Klinefelter's genotype is 44XO. This is 44XXY. It's a sterile male, sterile female. It's written here. Here everything underdeveloped like testes and feminine in male, the symptoms. Here the reverse, underdeveloped ovaries and breast, small uterus, short stature, mental retardation, cardiovascular abnormalities. That's it. So this is what the basic difference between Klinefelters and Turner, right? So don't get ever confused in the exam. Let's get back to the third questions, probably OBGY related, lot of questions coming into the exam. Almost your I can say 20-25% paper in exam is gynec, OBG, gynec, pedia, and general surgery. Concentrate on it. A 23-year-old lady was prescribed with azithromycin 1 gram for the chlamydia infection, pelvic infection. She has got a new boyfriend for last 2 months. She has recently started contraception to avoid the conception. Which of the following contraceptions method will be affected by the azithromycin? Barrier, IUCD, POP, that is progesterone only pills, and COCP means combined oral contraceptive pills. Take your time. This is little pharmac with gynec, I guess. Easy but tricky question. No? They are asking which antibiotic does this. So it's little difficult. Yes, Bahar Toprak. Any comment?
Um, yes, hello. I think this is chlamydia is a sexual transmit infection. I think barrier contraception is better, not the others.
Okay, so what contraceptions will be affected by azithromycin? What do you think? Whether barrier or IUCD or POP or COCP? Yes, Catherine. Any comment, Catherine?
Sir, I've opted for option D, combined OCPs, because I'm guessing azithromycin has something to do with the estrogen.
Yeah, you are brilliant, lady. Great. Good guess. Great. No. Let's see what other experts are saying. We have
Uh,
50 expert in the group, but only 2-3 people are commenting.
So I guess that there is this enzyme. What was that?
Which enzyme?
In this combined OCP, they have that what was it? Inhibitory effect.
Okay, so your homework is to find out all the details of COCP. One of the most widely popular contraceptive used across the globe, especially in Indian and Asian countries. Whenever go to the doctors, especially in rural area, okay, go and get the OCP. That's it. Am I right or wrong? You must be prescribing to your patients, isn't it? Right? So, what contains in the doctor OC pills? Combined oral contraceptive pills means they are combining something. Na? That is how it names comes, combined oral contraceptive. So, what they combine? What agent they are combining? What amount they are combining? What effect it is producing? Anyone voluntarily? Yes,
Estrogen and progesterone combined.
estrogen and progesterone combined. What is the effect of estrogen and what is the effect of progesterone?
In wait.
Yeah, go ahead. I'm listener today. You have to speak.
Estrogen is the hormone that supports the menstrual cycle, but progesterone is for pregnancy that supports.
Okay, so how? So I want to understand today. If I had given some pills to the female who comes to me and say me, sir, give me some pills which stops my pregnancy. I don't want to be a pregnant for 12 months, 1 month, 2 months, 3 months, blah blah, whatever. So I'm prescribing oral contraceptive pills, right? So how does when you ingest goes to the stomach, metabolize, goes to the body, how act, where it acts, how it acts exactly? You understand my question or not?
Progesterone doesn't allow the ovulation, sir. Prevention of ovulation.
Prevention of ovulation. So ovulation is not happen means when there is a no ovulation, there is no pregnancy, isn't it? No ovulation means
Yes.
no pregnancy, right? Right.
Cervical mucus becomes thickened, sir.
The secretion and stabilization, that is
Okay,
progesterone.
so that is another thing. One is ovulation. So it not, I mean, it stops the ovulation, it prevents the ovulation, it inhibits the ovulation, whatever, right? Another somebody told there is a cervical mucus thickening, so it won't allow even the sperm to get into the things, right? Because when the sperm and ovum comes into the contact, then there is a fertilized ovum, isn't it? Our embryology, if we remember, right? So when both are not meeting, there is no pregnancy, right? What is the most common complication you come across with oral contraceptive pills? That is again a second question in exam. What complication? What is the commonest complication and what is the dangerous?
Thromboembolism.
So thromboembolism is not common, but it's dangerous, isn't it? Sorry?
Hyperplasia,
Pregnancy, sir.
Sorry?
venous thromboembolism.
Failure of
Failure. So what? Failure of contraception
yes.
means pregnancy.
Yes.
Okay, great. Interesting. Right. Okay, so what advice you give to the patient while giving the oral contraceptive? Are you going to give any advice to the patient? So say patient, you had prescribed the oral contraceptive combined, say COCP, you advise patient. Are you going to give any advice to the patient that, okay, patient, you need to keep blah, 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 these things in mind? Or, okay, fine, you take it, nothing, there is no side effect. Go home, it's very safe drug. How you advise? You advise something, na? Right? When I give insulin to patient, I advise, see gentlemen, this is insulin. It will reduce your sugar. If you have hypoglycemia, keep the sugar, candy, blah, 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 blah with you. And if you have perspiration, you have tachycardia, you are uneasiness, you feel hunger, you feel dizzy, that means your sugar is down. Go and get it something.
Yeah,
Isn't it?
14 days.
Sorry?
Then 21.
Sorry, sir.
Take
Fine.
it on the 14th day of ovulation to 21st day. Then
Okay.
3 days there. Then you start 3 more tablets.
Okay, fine. So I mean, most of the answers are correct. I'm not saying no. Everybody is perfect. Yes.
Uh,
Yeah, speak up.
these macrolide antibiotics, inhibit CYP enzymes. They're responsible for their metabolism.
Now you remember lastly, doctor. Good. Great. Wonderful. So azithromycin.
Probably
Yeah.
Liver.
Yeah. Great. Wonderful. 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 You hit the dot. Anyway, so that's the perfect things. This is the answer for these things. If I ask you which is the safest form of contraception in same female, if I want to use this patient comes to me and say, sir, give me some contraception which is the safest for me, which is the best for me, which is reversible, which is has a least side effect, what I'll offer?
IUCD.
IUD.
IUD.
Excellent. You all are brilliant, very brilliant. No need my lecture. Wonderful. Combined oral contraceptive pills is just often called as a pills, right? This is the most common type. Each pills has the same amount of hormone, monophasic pills. One pills is taken each day for 21 days, and there are no pills are taken for 7 days, blah, blah, blah. These are the name of the things, right? So if you, I mean, azithromycin is a drug which inhibits the metabolism. So that is why it interferes with the azithromycin with the enzyme that doctor told, right? So everyone should know the contraception. Very frequently as sometimes ask this combined oral contraceptive, sometimes they ask IUCD, right? Sometimes they ask and say, for example, another question, right? This female has a sexual intercourse with the boyfriend. She comes to you after 6 hours. Which is the best one? Which is the best contraception?
Many.
IUCD can be given within 5 days. Sir.
Right. So answer is again IUCD. There were questions that female has a rape, right? And within 2-3 hours comes to the doctor. What contraception can be offered to the patient? IUCD. So you go and read it. What is the IUCD? What is the copper IUCD? What is the long-acting contraception? Right? Right. So these all are extremely important, right? And what are the contraindication of IUCD that we also get to know, especially the IUCD as well as the COCP or oral contraceptive. Frequently asked questions. Contraindication is also important, right? So you just not need to know the indication, but you just sometimes need to know the contraindications too, right? So this is the very interesting question. So you must keep in mind, right? Long-acting reversible contraception is the most effective contraception and safe. That is shortly called as a LARC, LARC. L stands for long-acting reversible contraception. And yeah, so long-acting contraceptions reversible is what? Long-acting contraception reversible. So long-acting reversible contraception is the same thing like IUCD, right? So you must keep in mind, go again and read it. So now you check your score. 3 questions we so far offered. Out of 3, how many correct, how many wrong? Make a note in your book. Fourth question. 33-year male involved in a street fight, present with a bruise and deformities in the upper part of his leg. X-ray shows the fracture of fibula. What is the single most associated nerve injury in this street fight? Sciatic nerve, gluteal nerve, musculocutaneous nerve, common peroneal nerve, tibial nerve, femoral nerve. Oh my God, this is most toughest questions. We forget the anatomy. Out of 52 answer. Yes, Catherine. Yes, Catherine.
Sir, I chose femoral nerve.
So this is guess or correct answer?
This is guess only, sir.
So this time, unfortunately, guess is not correct, right? Though it looks simple question, but we must know the anatomy. After this picture, probably your answer will change. See the picture and give me the answer.
Yes,
What
sir.
is
Option D. Common peroneal.
great? So this is clear cut picture. This is tibia. This is fibula. Very close to the neck of the fibula, common peroneal nerve is going, and they are clear cut mentioned that there is a fracture of fibula, neck of the fibula, fracture of neck of the fibula. So that's it. This is what the X-ray is seen, and in X-ray you can see neck of the fibula, common peroneal nerve. The fracture of the tibula, fibula or fibular neck fracture can cause compression of the peroneal nerve. The common peroneal nerve is a major nerve that runs around the neck of the fibula. Damage to this nerve can cause a foot drop and loss of the ability to dorsiflex. Eversion of the foot and extend the digits cannot be possible. So these are the 4 things which can happen with the peroneal nerve injury. Once again, foot drop, loss of ability to do dorsiflexion when you cannot do dorsiflexion, and extension and flexion, dorsiflexion, evert the foot, right, and extend the digits. Now, can anyone tell me in which now the wrist drop can seen? Wrist drop, like foot drop, there is
Radial
a wrist
nerve.
drop. A radial now, excellent. Radial,
Radial nerve.
R means R, wrist R, radial R, wrist R, radial R. So R, radial, wrist R. So wrist, if somebody asks you wrist drop, radial drop, that's it, right? What happens? Ulnar now, when ulnar now, radial wrist drop, ulnar, what
Claw hand.
specific? Claw hand, excellent, claw hand. So this is a key point. You must know, you should not miss this all word, right? So again, remember, wrist drop is a radial now. Then what for the ulnar, right? Radial, ulnar, then claw hand, claw, right? Go and see the picture, claw, right? Foot drop, peroneal now, peroneal, right? So these are the specific word which you must remember. You must know the things, not just the peroneal. They may sometime ask you, claw hand, which now is responsible? Radius, ulnar, this, that, median, which now, right? Claw means ulnar, that's it. So check your score. We so far reach. This is tricky, important, and check your surgical vascular knowledge. A butcher stabbed accidentally his groin. He bled so damn much that the towel was soaked in the blood and BP is 80 over 50, pulse is 130. Respiratory rate is 35 per minute. Here he presented to ER in anxious and confused state. What percentage of the circulatory blood did he lose? Less than 15%, 15 to 30, 30 to 40, 40 to 50, more than 50, more than 80. What's the answer? Take your time, 15-20 seconds. I am not in hurry. Yes, Azhil, Madana.
Yes, sir. I read that to develop hypolimic shock, a person will have to lose more than 15 percentage of his total like, blood loss. So he is under shock. So it should be like 15 to 30 percentage.
Yes. So how you classify this? What is less than 15, 15 to 30, 30 to 40, 40 to 50? How you classify? Tell me. On what basis? Or how you guess that, okay, this is for 15%, this is 30%, this is 40%. There must be some line of demarcation, isn't it? What do you think?
Yes, sir.
Yeah, so on what basis you decide? If you don't know, I'm happy. That's fine. Just say yes or no if you don't know.
Blood volume and patient's state, altered state, I guess. Blood volume, loss of blood volume is there, cut off.
Yes, Dr. Naina. You want to tell something, Dr. Naina? She is chatting in the box, so I thought let me ask her. Yes, Dr. Naina, any comment?
Yes, sir. Sir, I was just thinking that in reversible stage of hypovolemic shock, it is 15 to 30 percentage of blood loss.
So how do we know this is a reversible or non-reversible?
He is having tachypnea and he's having tachycardia. Those are negative feedback reflexes, basically.
Okay.
In hypotension, there'll be tachycardia and tachypnea, which are due to sympathetic overactivity. So
Okay.
that shows there is negative feedback responses, which actually occurs during reversible stage of hypovolemic shock. And reversible stage is usually less than 30 percentage of 15 to 30 percentage of blood loss.
Okay. So, I mean, don't take it otherwise, just trying to understand myself as well. So, do you have some literature on this, or this is the just guess, or you read somewhere, or what?
It is there in Ganong, sir. I'm basically a physiologist.
Excellent, wonderful, brilliant.
So it is there in Ganong.
Ganong. So, if you don't mind, do some
Yes, sir.
exercise and send that picture in the group. So, we also
Okay.
get little updated, right? I'm more of
Okay.
clinicians than physiologists. So, obviously, you are more expert than me in physiology, undoubtedly. I'm hardcore physician treating patients for years and years. So I'm just trying to understand. So I'm not refusing your the genuine proposal and talk,
Okay.
but I'm trying because answer is little different practically. It close
Okay.
to your answer, but as whatever the literature shows, I'm showing that only, right?
Okay.
So basically this criteria, if you can see the next slide, let me show you the next slide. This is the slide, right? Everybody can see this slide probably, right? If I can, okay, let me enlarge little bit more. Is it bigger picture for you? Yes or no? Can everyone see this? Yes or no?
Yes, sir.
Yes, sir.
Yes.
So this is what
Yes,
the
sir.
American Society is saying of surgeon for acute hemorrhage or blood loss. So this is acute hemorrhage. The butcher is cutting something and he cut the groin and is blah blah blah. Right. So first of all, we need to understand when the blood pressure is normal up to 30%. See, this is, I mean, simplest form what how we can remember. So this is not at all a normal blood pressure. Here the blood pressure is how much we have seen. Right here the blood pressure is very low, right? If you can see 80 over 50 is obviously low. It's not normal blood pressure. Are you agreed or not? Right? Yes or no?
Yes.
Right?
Yes,
So
sir.
this is a low blood pressure. So low blood pressure. So here you can see if you have less than 15% of the blood loss, you still have a normal blood pressure. So this is not good thing. How we judge in the emergency if I'm in a triage man, right? How I, oh, blood pressure is normal, don't worry. You carry on with the WhatsApp. Patient is stable. After 1 hour, patient become unstable because you miss the 15% loss. Less than 50% patient stable, less than 30%, up to 30% patient stable. How you look at it? Normal. I mean, blood pressure is normal. So your mindset is that oh, he's a stable guy. We never go into the pulse pressure. Pulse pressure is low, but we see the blood pressure. So BP, and we think usually, oh, BP is fine, he's fine, but it is not fine. He probably go from second stage to third stage very fast when the hemorrhage goes fast. So here the blood pressure falls, and when the start falling the blood pressure, it is at least 30 to 40%, or the up to 2000 of volume is already lost, means one third is lost, right? Say for example 80 multiplied by your weight is your total blood volume. So if your weight is 60 kg, so your how much is your blood volume? 4800, right? So if your weight is 100 kg, multiply by 80 is equal to 8000. This is the total blood volume, right? So average person who lost the 2000, right? 2000 is out of 6000, one third, 30% is one third. So one third blood is lost, then it has a circulatory effect. Now see the tachycardia. Tachycardia is there. Hypotension is there. Capillary refilling, you can see the low. Respiratory is 30 to 40. Again, our scenario, you go and check our scenario. What is this 30 to 40? It is fitting 30 to 40. So this criteria is fitting in 30 to 40%, 30 to 40 respiratory rate. Blood pressure low, blood pressure is low. This criteria is fitting. Anxious and confused, this is also fitting. Anxious, see here, anxious and confused, it's fitting. So this is in general considering and context of this scenario. This is 30 to 40% of the blood loss so far for this patient, right? And extremely bad is more than 40, respiratory rate is extreme, more than 40, and blood pressure is low definitely, pulse rate is all. So bad the hemorrhage, bad the tachycardia, bad the tachypnea, no urine output, and patient is absolutely confused and lethargic. That's it. So this is little arbitrary line between 3 and 4, right? But this is clear cut. 1, 2, or 2 and 3 is very clear cut. 1, 2 is almost close to same thing, and 3 and 4 is close to same thing. But at least you just keep two things in mind. When pulse rate is 120 to 140 is stage 3, and when the respiratory rate is 30 to 40 stage 3. That's it. So if you remember these two words, probably it will help you in the exam as well as in your emergency as well. Because when the patient comes to your emergency, you need to little triage the patient, that what is the stage of the hemorrhage, stage 1, 2, 3, 4, right? 4 is the worst one is better. Is that clear? Is that
Yes, sir.
clear?
Yes, sir.
Great. Again, go and read it. Doctor, I forgot your name. Sorry, physiologist. Ganong, just little drop in the
Sure,
group,
sir.
doctor, right? Just for my learning as well.
Sir, after I heard your explanation, I have a doubt whether I confused it with pulse pressure.
No problem. Go and check it. Don't worry. It's
Sure.
learning platform, so probably I may
Yes.
sometime wrong. I'm not a superman. Don't worry.
No, sir, I'll check it and put it
No
up.
problem. No problem. So we will improve our knowledge as well. I'm happy that a lot of brilliant people in the class. Excellent. So check your score out of 6. How much is right? How much is wrong? Move to the next hematology questions. Probably you'll learn a lot in this. Almost your everything is cleared. Lots of hematology cleared in next 5 minutes. But you need to know the diagnosis, because diagnosis is not there in this scenario. They're asking directly the another questions related with the diagnosis. So I intentionally created these questions for you guys for better understanding and learning. A 50-year male presented with early satiety, bone pain, abdominal heaviness, no comorbidity, vital stable. On examination, huge spleen, no lymphadenopathy. Lab shows HB 11.9. Total count is 35,000 per cubic millimeter. Neutrophil is 78. Lymphocyte is 10. Basophil is 1. Mono is 1. Eosino is 9. Which of the following abnormalities is seen in study in this patient? So first of all, you need to know what is the diagnosis. Then you can see the chromosomal study, or you see some this all fancy things. So here again my triad, any MCQ applies to all MCQ: diagnosis, investigation, treatment. So we have to have three answers. What is the diagnosis? How we investigate this patient? What is the treatment? So we start with the diagnosis. Open for all. Think and tell me. Let's give the opportunity to the new students. Midila and Haris both are super champion. Onkar is also champion. Yes, Varun. Yes, Varun.
Yes, sir.
What is the diagnosis?
Um, Sir, I wrote Hodgkin's lymphoma.
I want to understand. I want to understand. If you say Hodgkin's lymphoma, I want to understand. If you say leukemia, I want to understand. If you say lymphoma, I want to understand. If you say myeloma, I want to understand. Because this is the real hardcore subject of mine. So I want to understand. Now tell me, what makes you to think of Hodgkin's lymphoma, first of all? इसमें ऐसा क्या है जिसमें हमको लगता है कि हॉजकिंस लिम्फोमा है, दूसरा नहीं है? What makes you to think of Hodgkin's lymphoma? And whenever you are thinking of any disease, any answer, especially diagnosis, so when you say for Hodgkin's lymphoma, so tell me the point in favor, not in favor. Both the things are there. Na? In any scenarios, if you go and do the exercise for every MCQ, right, what point favoring your diagnosis, what point not favoring your diagnosis. This is how we do the diagnosis in clinic na? Every day. And you are also doing anyway that, okay, fine, you are saying, oh, this is viral, this is bacterial, this is this. How we know? By sign, by symptoms, by taste, by investigation, by presentation, right? This is how we differentiate. So you tell me what makes you to think of the Hodgkin's lymphoma diagnosis.
Sir, like he's a 50-year-old man, and the symptoms are vague. There are the WBC is high, and
Okay.
there is no splenomegaly and
No, there is a
lymph.
brother, huge splenomegaly, not no splenomegaly, huge splenomegaly,
Yes, sir.
written. No lymphadenopathy, huge splenomegaly.
Okay, okay.
If you want to change the answer, I would be happy. You can change the answer. This liberty, you will not get it in the exam.
No, sir, I made a mistake. Reading the question.
So I'll give you more 2 minutes while I'm discussing with the other gentleman. You think over it once again. What's your answer? Forget about what other people are saying the answer. If this question comes in your exam, how you interpret, how you diagnose, how you treat it. You got it. You have for 5 more minutes. Yes. Yes, Dr. Roshan, Dr. Shasi Ipar, Vidya Nair, anyone. I want
Chronic
to hear
myeloid
from.
leukemia, sir.
Who is this, sir? Sorry, I'm just.
I'm Javita.
Sorry, sir.
Javita.
Chavita. Okay. Yes, sir. So this is what is the diagnosis by yourself? I mean, by your sense, what?
Chronic myeloid leukemia. So the option will
Excellent.
be the chromosome translocation of 9 to 21.
Wonderful, 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 wonderful. So the answer is
Because
directly, sir said, this is chronic myeloid leukemia. So let's go bit in detail of CML, and I will try to triage all 4 leukemias in next 5 minutes. So no confusion will be there, right? Let me go to this page. I need a big page. This chart you cannot get in any book in the world, believe me. This is my own chart. First of all, understand acute leukemia and understand chronic leukemia, because we just speak what is acute, what is chronic. So acute by time frame, usually less than 3 months they present, they develop the symptoms. This is long standing. So patient is saying that I have a high WBC count for more than 6 months, which is rarely in acute leukemia, because acute leukemia, either he will die or diagnosis is not wrong. Untreated acute leukemia, they die within 3 months, for your knowledge, by bone marrow failure. So this is general time frame, right? Acute leukemia. The most important diagnostic point of acute leukemia, more than 20% of the blast cell is in acute leukemia. Here, no blast cell, no blast cell, or if at all, they're less than 5%. So how do you know? Do the bone marrow directly. Oh, 30% blast acute leukemia. Forget about everything. Presentation, this, that, older, young, middle age, blah, blah. More than 20% of the blast is acute leukemia. It's a definition. Write down in a bold letter in your notes. More than 20% of the blast, don't get confused, either in peripheral blood or bone marrow, is acute myeloid leukemia. So now onwards, anybody asks you what is the definition of acute leukemia, don't afraid, tell to your teachers as well, sir, if I see more than 20% of blast either in peripheral blood or bone marrow is acute leukemia. Forget about diversion. Again, two, acute leukemia which? This is acute leukemia. This is acute leukemia. Is it acute myeloid leukemia or acute lymphoid leukemia? We'll talk later. First understand. So less time duration is one thing. Another thing is a extremely is a blast, number of blast. Acute leukemia, chronic leukemia. Acute leukemia, more premature cells are seen. More premature cells are seen. More premature. And here more mature cells are seen. Mature cells are seen. What is a premature? It's a new word. What is a premature? So this is this is a stem cell. This is a totipotent stem cell. Let me give the brief idea. Hematopoietic stem cell. Here the myeloblast. Here the lymphoblast. Lymphoblast eventually give three types: B lymphocyte, T lymphocyte, and B lymphocyte, T lymphocyte, and natural killer cell. So hematopoietic stem cell, pluripotent cell, totipotent cell, hematopoietic stem cell, various type of stem cell. Hematopoietic will give rise to the complete rid of blood and bone marrow. So hematopoietic will divide into two mainly: myeloblast, lymphoblast. Lymphoblast is again giving rise to, so lymphoblast is a premature and this is mature, right? So premature and mature. 1 minute. Let me draw the little better picture. So I want to not to mug up you. I want to clarify you. So once you understand this cascade, 100%, any questions with leukemia you can answer. So this is hematopoietic stem cell. Hematopoietic stem cell give rise to myeloblast. This is lymphoblast. Myeloblast will again give to myeloid, right? Precursor will give the birth to the RBC, to the platelet, and to the four other cells: neutrophil, eosinophil, basophil, and monocyte. So where is the lymphocyte? Lymphoblast will produce lymphocyte, right? And natural killer cell, right? So this lymphocyte, right, is a B lymphocyte, T lymphocyte, and natural killer cell lymphocyte. There are three types, three variety, right? So myeloblast again is a tree where this all made by the myeloblast, right? So these all are, right? This myeloblast is a premature cell. RBC is in the blood, right? Platelet is in the blood, neutrophil is in the blood. So this all mature. So this is, I wrote here the premature more, here the mature more. See, here in AML more the premature. So if you see, when the acute leukemia develop, they develop at the little higher stage. Lots of premature cells, whether myeloid, if it is arise from the myeloid, it is acute myeloid. If it is at more than 20% of lymphoblast, it's a lymphoid. You understand? So acute myeloid and acute lymphoid, how you differentiate? If you have more than 20% of the myeloblast, right? More than 20% of myeloblast in bone marrow or blood, it is acute myeloid leukemia. Why? Because it is developed from the myeloid series. If something is happen here, and if something goes wrong with the more than 20% blast, acute leukemia, but which lymphoid leukemia? This is acute leukemia, which myeloid? Why? Developed from myeloid series. This all myeloid series. If developed from the lymphoid series, then it's a acute lymphoid leukemia, right? So the basic criteria is say more than 20% blast means acute leukemia, but which myeloid or leukemia? Then you have to see the second path. Second path is what? Myeloid or lymphoid, right? And when there is a lots of lymphocyte, considered is some kind of lymphoid leukemia. If it is more neutrophil, it is a myeloid leukemia. So let's go back to the scenario. Again, do the dissection, right? 50 years male, so middle-aged man, early satiety. Why is early satiety? Because he has a huge splenomegaly, and huge splenomegaly can compress the stomach and because of the compression of the stomach, if patient is just eating the one chapati, he feels that, oh, early satiety, oh, I'm done, I don't have much hunger. Because of the pressure on the stomach, the brain thinks that the stomach is full, and that is why the word is early satiety. So this is classical. Bone pain, right, because of high WBC count. Abdominal heaviness because of huge spleen, not large spleen, huge spleen. So normally, if I can tell you, this is a spleen on the left side, this is a normal spleen. What is huge spleen? This is a picture. Huge spleen, it comes up to the right iliac fossa. I have seen the patients in my 20 years of practice. I treated more than 500 CML so far and did the bone marrow transplant as well. So right iliac fossa. So it is in the left hypochondrium. This is spleen, so small, even it is not palpated. In normal individual, it is non-palpable. You cannot even palpate, right? Non-palpable spleen. And this is a huge spleen. This is huge spleen. Comes up to the right iliac fossa. Huge is very spleen, right? So what is the things, right? So this is huge splenomegaly, no lymphadenopathy. The point again, Varun, against the lymphoma is a no lymphadenopathy. Lymphadenopathy usually present in more than 80 to 90% of the patient with lymphoma, either Hodgkin's or non-Hodgkin. So here there is no lymphoma. Right. Another thing is you can see neutrophil up to 70%, 78%. So myeloid series is involved, somewhat myeloid series. So myeloid series is involved. Splenomegaly is there. Again, right, when there is a chronic, myeloproliferative disease, usually you see eosinophilia. Go and read it. So eosinophilia is present, right? So this is a classical case of CML. What point favors against lymphoma? You told, right? So if it is Hodgkin's lymphoma, usually it is seen in a young age. Usually, which is not young, 50 is not young, it's a middle age. Usually they have lymphadenopathy. There is no lymphadenopathy. They have Reed-Sternberg cell. You know the Reed-Sternberg cell? All eye cell. This is all eyes. Am I right or wrong? Yes or no?
Yes, sir.
This is all I Reed-Sternberg cell. So on Reed-Sternberg cell is seen in Hodgkin's lymphoma, which is nowhere mentioned. It is mentioned, right? Why it is not acute leukemia? Then discuss why it is not acute leukemia. Because there were no mention that it is more than 20% blast in blood on bone marrow. And when something is not mentioned in the scenario, means it is not there. It is normal. BP is not mentioned here, means it is normal. Here the height, weight not mentioned, sugar not mentioned, means normal. Is that clear? Right? So acute leukemia is not there, right? Then why it is not a lymphoid leukemia? Then why it is a myeloid leukemia? Because lymphocytes are normal. That is why lymphoid leukemia. Because when you are leukemia, means something is increased, na? If lymphoid leukemia, lymphocyte increase. If myeloid leukemia, neutrophil increase. So here high count, neutrophil is high, splenomegaly is high. So this is looks like a CML, chronic myeloid leukemia. If you see this scenario and if you read the book picture, you get exact the things, everything. Middle-aged man present with the early satiety, bone pain, even I can tell mild anemia. He has a mild anemia, leukocytosis, neutrophilic leukocytosis, presence of eosinophilia. Everything is there in this scenario. So if you have treated the patient, you can, without saying the answer, you can say this is a CML, this is this. That's it. So what is the investigation of choice? So we did diagnosis now, hopefully from our triad MCQ. So we are thinking that, sir, okay, fine, this is likely CML. What is the investigation? What is the best investigation of CML? If I tell you, you need to do only one test in this world which confirms the diagnosis, then what will you do? You
Sir,
do
is it phenotyping?
no,
Philadelphia chromosome.
no. Immunophenotyping is not for CML. That is the only differentiating point. Immunophenotyping for AML and ALL, even you can use for CLL, but cyto means cell, genetic means genetic material of the cell. What is the genetic material of cell? That is called as a chromosome. So another name of cytogenetic is chromosomal study or chromosomal analysis. What is chromosomal analysis? There are 1 to 23 pairs of chromosome, as we seen in Turner and this Klinefelters, right? So 23 pair or total number is 46. So what happens? There is a translocation in number 9 and 22. There is a translocation. What is a translocation then, sir? So this is a translocation. This is a 9 numbers of chromosome. This is a 9 numbers of chromosome, right? So this is a 9 number of chromosome. There is a ABL, and this is a 22 number. This is 9 number. So here BCR. So what happens? This BCR, so some portion of the ABL, some portion of BCR, they mutated, translocation, this part going this part going this. Trans means exchange, transfusion, right? Transplantation. So this is a translocation. So location, translocation means location is changed. Trans means one to another, another to one. Location means changing the position. So 9 numbers changing the position to 22 and 22 changing the position to 9. So what eventually develop is the mutated gene, right? And the gene name is BCR-ABL. Some part of BCR, some part of BR. So it occur at what end? 9 and 22. So ABL, right? ABL of 9, BCR of 22, they translocate and create one chromosome, and this created chromosome is called as a Philadelphia chromosome. Again word comes, sir, why Philadelphia? Because Philadelphia is in United States. It is invented in United States, so it is a Philadelphia. No logic. Is that clear? So what is the treatment? What scientists did it on these things? Scientists thought that something went at this level, something wrong at this level. If we block at this level, BCR-ABL level here in the Philadelphia, if we block this part, right? And what happens when this Philadelphia chromosome develop in CML? What happens? It will not stop the multiplication of WBC. 4,000, 10,000, 50,000, 100,000, 400,000. Keep continue, because there is no switch off. There is no cutoff. This is an unstoppable gene. Unstoppable gene. Producing. There is no inhibition on it. Naturally, in your blood and my blood, what happens? We don't have translocation. So we have a apoptosis, automated cell death. This is out of apoptosis. There is no cell death. Continue, right? So if you stop these things, stop the complete pathogenesis of CML, and there is a drug invented for this. Anyone knows the drug name? That's the treatment. The treatment is a imatinib. Have you heard of imatinib? Yes or no? Yes or no, brother?
Yes, sir. No, sir. No, sir.
No, sir. Okay, so go and read it. Today's homework is CML. I told you the interesting story with some basic and important logic with the easier concept, which looks very difficult to understand. So CML, there is a translocation of 922, number one. Another name is we called as a Philadelphia positive chromosome, right? And the oncogene, this is also called as a oncogene, right? Which produce the cancer. So oncogene is BCR-ABL. If you block this BCR-ABL gene by giving some drug, the name of the drug is imatinib. Imatinib. I'll take one time only separate lecture on CML. Very interesting. Imatinib, that is falls under the classification in pharmacology is TKI, tyrosine kinase inhibitor. TKI, tyrosine kinase inhibitor. So go and little bit read it. It's a miracle drug. In this drug invented in almost 2000, almost 23 years in the market, and it is called as a magic bullet. There was a article on the Times magazine in US when it was invented, first invented by the company called as a Novartis. I'm going bit in detail. Novartis is the name of the company, and the inventor is a Brian Drucker. Write down, everybody. Spend some time. Don't see the Instagram. Don't see the reels. Don't see the Facebook. Look at the Brian Drucker. Today's night homework is a Brian Drucker. Who is a Brian Drucker? So Brian Drucker is the fellow. He worked with the Novartis, invented this drug, blocked this BCR-ABL, and this gentleman get Nobel Prize. Very interesting story. Go and read it. So drug is imatinib. Before imatinib era, I just deliver 1 hour lecture to one company's representative on imatinib. So I knows bit in detail because I did a lot of research. So this before CML, before 2000, what happens? When diagnosis CML, they die in 2 years. What? Because CML has three phases: chronic phase, accelerated phase, and blast crisis. So when they comes in blast crisis, within 3 months they die. So since diagnosis, they die in 2 to 3 years. That's all. Story over. What happens after imatinib? I know the patient who is living more than 15-20 years because I started my practice somewhere in 2002, 2003 in hematology, almost 20 years now. So those patients who are early to my practice in 2005, now 2024, 19 years, they are in my follow, living 19 years. One patient who is unmarried, got married, have a normal kids, is enjoying his life. His name is Samir Thakkar in my city. There are thousands of success story. So this drug is a miracle. This is the bullet drug, and this open up the way for targeted therapy in the world of medical oncology. So long story, but I try to make it short. So I'll go little quickly. Is that clear to everyone? Any question with CML? I tried my level best to explain you. Any question to CLL?
It's clear.
Anyone? Wonderful, wonderful, wonderful. All you are very brilliant.
Sir, can I ask a doubt?
Yeah. No need to ask. Can I ask you? You ask everything. This is a learning
Sir,
platform.
is there any screening test before the confirmatory test, which if suppose they ask, how would you come about to the diagnosis before?
Interesting questions, but I'll answer you this properly. This CML, two things is extremely important, doctor. Honestly speaking, I treated hundreds of CML. So I'm giving you the overall, the experience of my years. Splenomegaly and neutrophilic leukocytosis. These two things are good enough to think of CML in primary phase, right? What the two words I mentioned, splenomegaly and neutrophilic neutrophilic leukocytosis. If it is a lymphocytic leukocytosis, my mind is diverted to lymphoma or CLL. You understand? Lymphoid leukemia. I'm talking about myeloid leukemia. CML is a chronic myeloid leukemia. So more than 3 months is a chronic. Myeloid means neutrophil involved, and leukemia means less than 20% blast in blood or bone marrow. Is that clear? So splenomegaly plus neutrophilic leukocytosis. So when I get a reference in my hospital, say for patient, there are hundreds of patients who has a neutrophilic leukocytosis. So everybody has not CML, right? But in patient when admitted to the hospital, number one is infection. Somebody has high count, somebody has neutrophilia, bacterial infection. Isn't it? Yes or no?
Yes, sir.
Right? So what my ICU people do in my hospital? They give antibiotic, meropenem, estrionam, this, that, targocid, clindamycin, whatever the high-fi antibiotic they all give. Then they after 1 week they're tired. Before antibiotic 30,000, after antibiotic 30,000. Now what they are little disturbed. Why the counts are not going down? You understand? Then I comes in the picture. I'll see the bone marrow, or I see the first peripheral smear. I go for neutrophilic leukocytosis. I look for the long 6 months before CBC. Even before 6 months, it is a 30,000. But that part is missed by the history. You understand? So something is not acute, something is chronic. Last year he did a body checkup last year, and at that time body checkup WBC was 25,000. So I got the clue. This 30,000 is not new. He has a 25,000. So 25,000 is also new. So it's chronic. Is that clear? How I know this is acute anemia or chronic anemia? Whenever I am treating today patient one, it's admitted under me. Hemoglobin is 6.5 gram. I ask, what's your last? Have you ever checked? Yes, sir. I checked the hemoglobin last year. How was that? 8 gram. That is also low. So this is not acute leukemia. Before 1 year he has 7. Now he is 6.5. So it's a chronic anemia. One year he has a low. So that is why the history is important. You understand, right?
Okay, sir.
So basically leukocytosis, neutrophilic leukocytosis with splenomegaly, especially the huge splenomegaly. There is a one chapter in the Harrison. Go and open it. Causes of huge splenomegaly. Causes of huge splenomegaly. One of them is CML. Another is malaria. Third one is a Kala Azar. Fourth one is a storage disorder. Fifth is a lymphoma. You understand?
Okay, sir.
So one of them is a massive or huge. Always think of CML, especially high count neutrophilic. Once I get a clue in my brain, that, okay, fine, this is CML. Now what I want to do exactly? Let me tell you one more thing. So it's very important questions. I probably take 2 more minutes, but it's very important. So whenever I suspect CML by splenomegaly, by increased neutrophil and WBC, right? I have choice, either I go for bone marrow biopsy, and in bone marrow I ask for two things: cytogenetic, right? That is chromosomal analysis. After doing what, I'll look at 922 Philadelphia. If it is there, 100% diagnosis is CML. Is that clear? Yes or no?
Yes, sir. Yes, sir.
There is
Clear.
one another test that is called as a BCR able by PCR, real time quantitative PCR. Have you heard of PCR? Polymerase chain
Yes,
reaction, right?
yes, sir.
So RQ-PCR or real time PCR. So you can detect this from blood as well, just your knowledge. So if some
So
patient says, sir, I don't want to do the bone marrow.
that also comes under confirmatory test from litmus, sir.
No, it is not mandatory. No, 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 no. If you have CML, if you have cytogenetic positive, you can start the imatinib. You can start the imatinib, but there are three response. Just, I mean, going bit in detail hematology, right? One is called hematology response, one is called cytogenetic response, and one is called molecular response. So molecular is monitored by BCR-ABL, cytogenic monitored by the cytogenetic, and hematological response monitored by CBC. So we need to do, definitely, we cannot avoid this test, right? Either in, right? So when you are doing the bone marrow, I'll ask two tests to the patient. One is cytogenetic and another is PCR for BCR-ABL. And it comes in the percentage, right? How many BCR-ABL comes out of 100 chromosome? If it is 100 chromosome, have all the 100 chromosome, and 100 BCR-ABL means 100%. 100 chromosome and 90 BCR-ABL, 90%. 100 chromosome and 50 BCR-ABL, 50 normal, 50%. So why it is important to know? Say for example, at diagnosis there are BCR-ABL is 100%. After 3 months of imatinib, it is a 10%. After 3 months, it is a 1%. After 1 year, it is a non-detectable, means excellent response, isn't it? How do I monitor CML? By this test. And every time, every 1 month, I cannot do the bone marrow. This can be done from the blood as well. You understand? BCRL is done from the peripheral blood. It can be done from bone marrow.
So therapeutic response can be monitored by measuring the BCR-ABL gene percentage.
Exactly, from peripheral blood. So every 3 monthly, when I'm treating, just now one patient, we did, I'll share you how the BCR-ABL report comes. I did it yesterday only for my patient. He's a known CML on imatinib, right? 400. So this is how we monitor, right? Every month you can say that, oh, chalo, come every time, bone marrow, bone marrow. He will, he will run away. He will change the doctor.
Okay.
You got it. So at the time of diagnosis, anyway you are going to do. Then you think, sir, why, if it is done from the blood, then why you want to do the bone marrow? That is again a matter of discussion in our lot of national and international hematology conference. You understand? When I'm saying you that, okay, BCR-ABL is positive from PCR from peripheral blood, then why you are doing the bone marrow and picking a big needle and this a Jamshedi needle in the posterior superior iliac spine, paining the patient, cost is more, patient is painful, may not be ready, then why you want to do the bone marrow? The bone marrow is important because you cannot see just 922, but you see complete 1 to 23 pairs of chromosome, and sometime along with the translocation in 922, you can see chromosomal changes in number 1, number 20, number 18, number 14. More complex or more than 3 chromosomes are involved along with 922. It is called as a complex CML. What you call atypical CML, and prognosis is not good. That is why we need to do the bone marrow biopsy. Is that clear?
Yes, sir.
Okay, so probably I went in detail. Sorry for that, but it's a very interesting story.
No, thank you, sir. Thank you.
I cannot stop myself when hematology comes. Sorry.
Thank you so much, sir.
No problem. So we just discussed couple of questions more. We finished 1 hour and 14 minutes so far. I'm on time. I will finish it off in next 10-15 minutes. A new screening test has been devised to detect early stage of prostate cancer. However, the test tends to diagnose a lots of people with no cancer, although they do have a cancer as diagnosed by other standard test. What is this flow called? False positive, true positive, false negative, true negative, poor specificity. We always heard of lot of things, no? Looks like today's questions are a bit tricky and toxic. Gulsen, what do you think? These questions are tricky, Gulsen? I think Gulsen left the class. Yes, Jomoli. I did not heard from you today.
Sir, I joined the class little late, sir.
No problem.
Sorry.
So, no, it's fine, doctor. No need to be sorry. It's open platform. Have you listened these questions? Did you get to
Yes, sir.
these
Yes, sir.
questions? So what's your comment?
Sir, it's false positive.
False positive. So explain me why it is false positive. What is false and what is positive? Or this is guess or just you knows the answer or what?
No. Um, Sir, I'm trying to read
In
it.
this the question, they have mentioned that the person is having cancer before, but when that particular test was done, it was diagnosed no cancer. So in that test itself, it's missing cancer. It's giving a false positive.
So sorry, it's a very confusing question. So first of all, tell me, anyone, you doctor, tell me, you're discussing. Na? So this patient has cancer or not cancer, first of all?
Not cancer.
Hmm?
He has.
This patient has cancer, yes or no? This is the first primary
Yes.
question. Yes, so no. So who is say no?
No cancer. It's a people with no cancer.
Yeah, so this patient has no cancer. Let me read this question again. A new screening test has been devised or developed to detect early stage of the prostate cancer. So they want to detect the prostate cancer in an early stage. So they have implemented or they introduced one test. What happened? However, tests tend to diagnose a lot of people with a no cancer. Although they do have a cancer as diagnosed by the other test. So they develop one test. Say for example, a test they have developed and they do whether prostate cancer is there or not. So the a test is saying there is a no cancer. No cancer. This is what I understood. You can rectify me. But in this no cancer patient, they have another excellent another test, B test, which detect, oh, they have a cancer. Although they do have a cancer as diagnosed by the other standard test. So one test is also standard, B test is also standard, but A test cannot detect. They say there is no cancer. Another B standard test say that there is a cancer. So what is this? Am I right or wrong? Did I understood properly or not? Yes or no?
Yes, sir.
Right. So what is this? This is false positive. This is true positive. This is false negative. This is true negative. What's this?
It's false negative.
Excellent. New question, new answer comes. I'm happy. Yes. Anyone? Anyone full false positive? Anyone? I don't think so. This is so much of that much of complicated question, isn't it? So go and read it. False positive. This is the 4 block. Test say you don't have it. Test say you don't have it. You really don't have it. So test two things. See, test, right, and disease. So test is different thing, disease is different thing. Say for example, I have malaria, but the test say there is a no MP by card is negative. Come on, I have a malaria. I have a symptoms, I have a rigor, I have headache, I have fever, I have fatigue, everything I have it. But test is saying no malaria, and I do some other test, it's showing, oh, Dr. Munjal, you have malaria. So what is this? In spite of having the disease, the test cannot pick up, right? Test cannot pick up, and that is what the thing is. What the thing is. So see here, don't get confused yourself, right? It is a very simple, you just need to understand. So test use, right, test says you don't have it and you really don't have it, means it is a true negative. You do not have malaria, MP by card is negative. Test say you do have it, you do have it, but you don't have it, means you do not have malaria, but test say you have a malaria. then it is a false positive, right? Test say you don't have it, but you really have it, then it is a false negative. So when you have it, but the test does not detect it, it is a false negative, and this is a worst part. It is a worst part because test, right, false negative, right? It's not negative. That is why what is false negative? Disease is there, but the test cannot detect it. Somebody has HIV positive, but test say there is no HIV. It is false negative. It is false negative. If you do the Western blot, same thing say, oh, now you are not negative, you are positive. But it was missed in the ELISA, it missed in the rapid test, but it picked up in the Western blot. That is the highest sensitive and specific. So when the disease is there, but test cannot detect it, it's false negative, right? The test, you do not have it, but you really do have it. So you have a disease, but it is not detected by the test. If you have disease, it is detected, it is a true positive because you have a disease, right? Somebody has HIV and test is positive, so it is true positive. False negative is what? You have HIV, but test say you have no HIV. It is false negative. He has HIV, but test is not showing. So the same thing here, the prostate cancer, they are detecting one test, right? So initial test, the one test tend to diagnose people with no cancer, although they do have the cancer diagnosed by the standard test. So every test has their own limitation. That is how the word comes sensitivity and specificity. Sensitivity is what? Again, a question exam in this Gulf, right? Sensitivity means the patient has a disease and they are the positive. That is sensitivity. And specificity, when the patient has no disease and the reports are negative, it is called specificity. So sensitivity will pick up the positive patient, specificity will exclude the negative patient. That, so say for example, I can say 99% of the specificity of test means what? If you check 100 normal patient, 100 per normal patient, 99% are confirmed negative, means 1% is still doubtful. So higher the sensitivity good, higher the specificity is good. And that is why all screening tests are made, like mammogram, pap smear, stool for occult blood, colonoscopy. They all are made on the sensitivity first and then specificity. Means if the disease is there, they should be positive. And when the disease is there and they should be positive, it is called as a true positive, and sensitivity is high, and high sensitivities, it's a good viable test in the market. Say for example, if you miss lots of HIV, right, even though they have HIV, but your test cannot detect, means see how many positive are moving around in the market, even though they don't know I have HIV. Why? Because test is negative. You understand? So this is answer is answer is answer is I'm asking
C.
you guys.
C. False
See,
negative.
false negative. Why? Because disease is there, right? But it is falsely showing negative. If you do it with the standard test, they are positive, right? So when disease is there, but it is not picked up by the test, it's false negative, right? So this is, I think, the important, simplest chart. I try to look for more literature. For 1 hour of my lecture, I do 10 hours exercise. Then I can able to present it properly to you. You got it? So the simplest block I get this. There are lots of confusing blocks, but this is the most one. Go and read it once again. Sometimes in epidemiology, they can ask you 2 questions only: false positive, false negative, sensitive, specific. Sensitivity. Go and read it once. 35-year woman present with a visual problem. CT brain reveals pituitary tumor. What is the most likely defect? Homonymous hemianopia, homonymous upper quadrantopia, bitemporal hemianopia, cortical blindness, homonymous lower quadrantopia. Complicated name.
C. Bitemporal hemianopia.
Are you a neurologist? Doc? Who has given the answer?
No, sir.
Your name? Yeah, don't apply. I'm not bad guy, don't worry. Only 3 answer out of 50 people in class. 10% response. What is hemianopia? Hemianopia means what? Hemianopia. Yes, doctor, you told me.
Can't see half the side, sir.
Half side, which side? Central,
In
upper,
this
lower.
case,
Sorry?
in this case, temporal, which means like for left eye, it's on the left side. For right eye, it's on the right side.
Excellent. You are neurologist, doctor?
No, sir.
Great, I'm happy with the answer. So basically, it is a matter of understanding this chart. If you understand this chart, no need to mug up. This is our old physiology. Doctor better understand this. I think doctor is there or not physiology.
Yes, sir. Yes, sir.
Wonderful. So teach us physiology. Take one lecture for us physiology. Request.
Okay, sir.
Wonderful. Because our physiology is not good. Our pathology is good. So visual pathway, this is sclera. This is, I mean cornea, sorry, sclera. This is a retina, right? This is left and right. This is optic nerve. So one is what? Optic nerve. So one is this, right? So one is this, right? So compression or damage at the optic nerve, what happens, right? So defect in the left side, right side is normal, right? Second thing is this is called as the optic chiasma. Have you heard of this word optic chiasma? Yes or no? Optic
Yes, sir.
chiasma. So optic chiasma is where the merging of right optic and left optic. And let me tell you, the pituitary tumor is situated here only. Pituitary tumor is situated at optic chiasma. Then what happens? Right side right and left side left. As doctor told, it is called as a bitemporal hemi. Hemi means half. Temporal means temporal side. So both side half of the vision is gone on the temporal part of the eyeball. This is called as a bi, means both side. Temporal means temporal region, and hemi means half. Anopia means absence of vision. Simple, no need to mug up. Bitemporal hemianopia, right? So this is in the optic chiasma. So if somebody asks you optic nerve injury at the level 1, what is the defect? Don't get confused. It is not bitemporal, then it is a complete loss of, right? Because there is complete cut off. So completely left eye is completely gone. Little less is bitemporal, and this is homonymous. Homo means same. By homo, same side. Both right side, both gone, right? So this is third. When there is a problem in the occipital lobe, especially cerebrovascular accident, CVA, cerebrovascular accident or event, you can see such type of visual defect. If your pituitary tumor usually situated at optic chiasma by temporal hemianopia, and if it is at the optic nerve level, it is complete loss of the vision. So no need to mug up. Just keep this chart in mind, I guess. I try my level best to make your job easy. Is that clear to everyone? Yes or no?
Yes, sir.
Wonderful. Last couple of. Check your score. I did it 8. 37-year-old woman believes that her neighbors have been using her shower while she is away from home. Her 42 years old partner is convinced about this and call the police. What term best describe this situation? Capgras syndrome, Cotard syndrome, delusion of persecution, Polydux, Munchausen syndrome. Very toxic questions. Psychiatry. Psychiatry. Sorry to ask you a lot of different subject questions because exams full with the variety, not only gynec. Yes, anyone. Anyone. Delusion of persecution, D, Polydux, lot of C. So let me jump to the answer directly. The answer is D. The fall paradox means shared madness or madness of two. In French, if three people share the delusion, it is called folly or trois. What is the most common folly? Dukes, right? This is blah blah content that the most common delusion is fall edukes in is persecutory. There are lots of when I was investigating these questions, I became mad. I became mad, believe me. Lots of even a classification of fall edukes. One of them is persecutory. Like that, there are a lot of sub various types. The belief that someone or something is out to destroy the couple. The makes most delusion is that delusion of grandeur. The shared belief that the couple is better and more entitled than those around them. So this is the specific condition you need to know. I know this is little toxic, but many people still in this class confuse what is delusion, what is hallucination, what is illusion. So when you see the magician, have you seen Jadugar, magician? Jadugar is a illusion. Jadugar is illusion. Running the horse in your window, you are seeing that oh somebody, I can hear some voice from my window. It's a hallucination. And delusion, false but fixed belief that Dr. Munjal is going to harm me. I'm not going to harm you, but you have false but fixed belief. That is delusion. Illusion is magician, right? He is changing the color of flower, right? Blah blah doing is a visual illusion. And hallucination, either visual hallucination while you are seeing in your dream that horse are running outside your window. It's a visual hallucination. You are seeing that your mother, your somebody's diseased close relative who died 10 years back, now you can listen her noise. It's auditory hallucination. So you need to understand the clear cut definition of delusion, hallucination and illusion. So go and check it. Last questions for today probably, I guess. A 32-year-old woman with a history of depression comes to the emergency department 30 minutes after taking a bottle of pills in an attempt to commit a suicide. Blood pressure is 118/70. Pulse is 90 per minute. Respirations are normal at 14 per minute. She refused to tell you what she took. What is the most appropriate next step in the management?
The
Induce
gastric lavage.
emesis, IPEC, gastric lavage, psychiatric consultation, naloxone, flumazenil. Get 15 seconds, think over it. Tell me, I'm not in a hurry. So B, 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 B. So everybody's B. Why B, doctor?
Because
Because
less than
that's
30 minutes.
45 minutes.
We can
Sorry,
restart.
one by one. Yeah, sorry.
First
Yes.
30 minutes we can give gastric lavage.
Okay, up to how many minutes you can give like gastric lavage?
30 minutes.
Sorry?
30.
So you start at 30 or up to 30 minutes?
Within 30 minutes, sir.
Okay,
Then
within
1
30
hour.
minutes.
Ideally within 1 hour.
Ideally, one is saying 30 minutes, one is saying 1 hour, means 60 minutes. Anything else? Anybody 90 minutes? Anybody 120 minutes?
Ideally within 1 hour, maximally up to 2 hours.
Excellent. So this is the perfect answer, right? So earlier the better. In short, earlier the better. But fix one thing on your head, which is more important. You mention it very properly, so I have no doubt. Just hold on for a second. Yeah, so basically one thing is fixed in this case. Less than 2 hours, think of gastric lavage. more than 2 hours or 120 minutes, forget about gastric lavage. So three things I told you in my past lectures. One is the time is important because time decides. Say for example, less than 2 hour gastric lavage. More than 2 hour, I'll think of antidote. More than 12 hours, I think of hemodialysis. Same scenario, change the answer. Same scenario, change the answer. So time is important, extremely. Three questions. Second is important is the drug agent or drug name. What consumed? What consumed? Paracetamol, N-acetylcysteine. Aspirin consumed, urinary alkalization. Lead poisoning, right? Then penicillamine. Copper poisoning, penicillamine, right? So depends on the drug, you need to decide the antidote. So what drug they consume is important. And third question is important. Only these three fundas, if you remember, you can answer any poisoning. So first is time, second is drug, and third is a dose. If somebody says, sir, I have consumed 5 grams of paracetamol in 24 hours, I will tell, brother, go and sleep. No need to worry, right? You will be absolutely fine. If somebody says 10 grams, sir, I consumed 20 grams in 24 hours, I am worried. And somebody is saying, I consume 15 grams paracetamol, I am extremely worried. This patient may die because of hepatic failure. See the dose impact. 4 to 5 grams per day paracetamol, to be precise 4 gram rather, is a therapeutic dose. So you can give to the normal patient. If patient comes to you with 104 fever, right? So 1 gram in morning, 1 afternoon, 1 evening and 1 night, 4 gram per day, 24 hours. It's a normal therapeutic dose you are giving to the patient. You are not killing the patient. You are giving to cure the patient. But if this 1 become 2, then it is 8 gram. When it is become 3, then it is a 12 gram. And when it is 4, 16 gram, right? This 16 gram means death. And when somebody is taking 16 gram at a single time, 16 gram, got it with the water, tomorrow morning he'll die. Hepatic failure. Is that clear? Yes or no? Tell me yes or no. Yes or no?
Yes, sir. Yes,
Right?
sir.
So these three things you have to answer. Forget about everything. What consume, blah, 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 blah. Just ask three questions to yourself. Time, drug, and dose. Let's apply this practical on this case. Is that clear? So this is real time case scenario. My three formula we need to apply here. So first of all, let's see time. So what is the time frame here? Right? 30 minutes after taking bottle of pill. So 30 minutes. Or into bracket, you can say less than 2 hours. Right? So little think of lavage. Is that clear? Agent or what drug they consume and what dose. So let's see. Tell me what drug? Attempt to suicide. So they did not mention what drug, isn't it? There are hundreds of bottles which can make suicide. You understand? But there is no specific paracetamol, aspirin, morphine, naloxone, blah blah. Any drug name they did not mention, right? And their dose they also did not mention, right? What they are asking, within 30 minutes, somebody with unknown substance. So any unknown substance in the stomach within 2 hours you can remove it. That's it. Simple. Why? Because it is not going in the systemic circulation. Again, literature, less than 1 hour, 50% you can remove. Less than 2 hours, more than 1, and less than 2. So 60 to 120 minutes. Within 60 minutes, 50%. 60 to 120 minutes, 15%. And more than 120 minutes, absolutely no advantage of gastric lavage. What? 95% of the drug gets into the system. When it is in the blood, what will you do by passing down the tube in the stomach when there is no drug in stomach? Why? Because 95% is drug gone from stomach to the circulation. No use of giving lavage. Is that clear? Yes or no? Tell me yes or no. Yes or
Yes, sir.
no? Great. So this
Yes,
is
sir.
how you have to answer. And another questions, one more question. In this, then we'll end up this session. Right? When patient says, I don't know, right? There is one scenario, another MCQ in exam. You will come across probably, so you can answer better. In exam, they say patient comes drowsy. They don't know drug, no drug name. They don't know the dose. They don't know the time, and they don't know the drug name. Nothing they knows. Scenario is like this: 25 years of female found to be collapsed in her house. After the parents coming home, she found unconscious, right? They thought that she consumed something, but what consumed, what time consumed, what amount consumed, nothing knows what to do. What is the treatment of choice? Treatment of choice is, write down TONG protocol, TONG, T-O-N-G. T stands for thiamine, O for oxygen, N for naloxone, and G for glucose or dextrose. Write down TONG protocol. This is called as a cocktail protocol. When you don't know nothing, give tongue. That's it. You don't know anything, na? How you are going to give the antidote? So give tongue. If it is not there, even it will helpful. Why tongue? It's decided internationally. Thiamine. Why? Alcohol abuse, alcohol overdose is very, 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 very common, and they try to suicide with excessive alcohol, right? And they develop the vernix encephalopathy. Have you heard of vernix encephalopathy? Yes or no? So thiamine, yes or no? Yes or no?
Yes, sir. Yes, sir.
Thiamine is vitamin B1. It is given oxygen. Hypoxia can kill patients, so you don't want the patient to be hypoxic. On brain injury, so give oxygen. Morphine, again commonly abused recreational drug. People are used to have enjoyment. Morphine, antidote is naloxone. And extremely important in medical practice, I've seen hundreds of doctors who did suicide because of insulin overdose in my city in last few years, especially doctors and nursing. They close the room, take a 40, 80, 100 units of insulin, sleep night, morning gone. That's it. So when you don't know, these are because these are common, na? And you don't know. So give them, na? Give them. There is no harm of giving, na? If you give glucose, what is the harm to the patient? Nothing. If you give thiamine, it's a simple vitamin B1. What's the harm? Nothing. If you give naloxone, if there is no morphine even poisoning, and if you are giving naloxone, patient will not die. Anyway, he is dying by not doing anything. So these are the four common things internationally they created. So when you knows nothing, give tongue. That's all for today. It's time for little quick feedback. Very quick feedback. Anyone, those who joined first time and wants to share something which is absolutely new and interesting and fascinating to him, just share. 1 minute. Anyone, open for all. Anything new learning today? Probably a lot of new learning, I guess, but still something is very, very, very new. No one, no feedback. Give, doctor.
Really beneficial for me because 10 question I have just two true is too much beneficial for me.
No problem, doctor. I'm happy. Anybody else? Anyone else? No comment.
Sir, you made our hematology concepts far more clear than any other subjects. So even if we think we know something about the topic, but after listening to your class, it becomes more clear and we realize how much we know actually.
Sorry, how much?
After listening to your class, sir, we realize that whatever work we do in self-studies is actually not enough.
Join
So
coaching.
when we get to hear,
Simple advice.
so when we get to hear something from an expert, it stays in the head more.
100%. That is why I'm here, na? Otherwise, everything is in MTB, Harrison, Davidson. But the way I explain probably this time and dose and drug and what to do, that does not explain in the book, na? You understand?
Yes.
So this is all clue which we got it from our practice. I mean, everything, most of the things is not written in the book, right? But how do I get to know? Because we do the patients, treating the patients and making some R protocol. What is the important 1, 2, 3 point? That is why we make some conclusion that if you do this, it would be easy for you to treat the patient. You understand? That comes from the
Yes.
experience.
Yes, sir. Yes, sir. Thank you so much, sir.
No problem. So thanks everyone for joining, and let's connect again very soon, probably the Sunday, because I was busy yesterday, so I could not make up. Sorry for that. But again, from the Sunday, probably we'll catch on the 11 to 1. Pallavi will post it in the group. Thank you very much, everyone. Just keep
Thank
in
you,
touch,
sir.
and you can post your further
Thank you, sir.
this follow up and feedbacks in the group. That makes us improve. Why I am getting the feedback? Because I also probably need some improvement in my coaching. I try my level best every time. I do my best, right? But still, I want to improve. That is why I'm asking your feedback. So whatever is there, you just post it in the group. Thank you very much, and enjoy your evening.
Thank you, sir.
Take care. Bye bye.
Yes, sir. Thank you, sir.
Bye bye.